All right, so our next topic is autonomic dysreflexia. I'm going to try and quickly get through some bios just so the speakers can get started. We have Kendra Baker, and in the last year, she's taken a position as the clinical nurse educator for tertiary neural rehab at Foothills Hospital. We also have Rebecca Charbonneau. Dr. Charbonneau is a clinical assistant professor in the Division of Physical Medicine and Rehab in the Department of Clinical Neurosciences at the University of Calgary. She's also the medical lead for spinal cord injury rehabilitation at the Foothills Medical Center in Calgary. And we also have Kasey, Aiello. She's been working with AHS since 2018 as the patient liaison for neurosciences at Foothills Medical Center. And she has 23 years of experience living with an SCI as a quadriplegic. She currently supports 4 groups of peer support volunteers who have lived experience with an SCI, BI, stroke, and seizures.
All right, thank you guys so much for the introductions. So our talk today is going to be reviewing autonomic dysreflexia. So next slide. So throughout the talk, we'll kind of interchange AD, autonomic dysreflexia, or just dysreflexia. And the outline for our talk today includes discussing the definition of AD, the pathophysiology, the causes, and then we're going to review the management. And finally, Kasey will give us a description from a perspective of a person living with spinal cord injury. Next slide, please. So AD is a potentially life-threatening emergency that can occur in individuals with spinal cord injury at the level of T6 or above. It's defined as a sudden, significant increase in both systolic and diastolic blood pressure of at least 20 millimeters of mercury. Often, bradycardia is seen classically with AD, but tachycardia may be observed as well. Next slide, please. So again, this can happen in anyone with a spine injury above T6. And to understand AD, maybe we'll take a step back and just talk about what happens in the setting without a spinal cord injury. So, typically a person will experience pain. The body will send this message to the spinal cord, and then this will go up to the brain. Then the brain will turn around and control the body to respond. So for example, prior to a spinal cord injury, say you have a full bladder. This is going to send a message to the brain and say, hey, it's getting kind of full down here. And then the brain is going to direct the body to find a bathroom and then signal the bladder to go when it's appropriate. So fast forward, after a spinal cord injury, so after the spinal cord is injured, the situation is sort of what's displayed in this image here. So the message of this full bladder doesn't get to the brain. So it's blocked at that T6 injury in this case. And the brain also can't communicate with the rest of the body. So the brain just doesn't really know something's wrong, and that bladder will keep expanding and expanding with urine, and this can be really painful. So even though this pain isn't really felt by the brain, the body knows. So think of AD kind of like the body's backup plan for when the brain doesn't respond to pain. So because the brain isn't getting the message of this pain, those blood vessels are going to start constricting below the level of injury. And we won't get too technical here, but basically it's, a massive sympathetic discharge. So your fight or flight response is going on. All these blood vessels are constricting and they're not appropriately dilating. So they're not expanding because of the signal from the brain is not getting down now via the spinal cord because of that injury to the rest of the body. This in turn makes the blood pressure increase, and this is AD. Episodes of AD can result in extreme elevations in blood pressure. So we're talking as high as 300 systolic. And untreated episodes of AD may have very serious consequences. So this could include things like intracranial hemorrhages, retinal detachments, seizures, cardiac arrhythmias, myocardial infarctions, and even death. AD does not routinely occur really early after spinal cord injury, so in those first couple weeks or so. And if AD is going to happen, it usually occurs for the first time in that first year. So in 92% of the cases, it's going to happen in that first year if it's going to happen kind of going forward in someone's life. It's much more likely to occur in a complete injury or ASIA A than the other ASIA categories, but it can occur in anyone after spinal cord injury. Next slide, please. One really important thing to keep in mind is that people with spinal cord injury often have low blood pressure. So this autonomic nervous system, that automatic nervous system, kind of controls the blood pressure. And because there's that disruption of the nerve impulses at the level of the spine injury, the autonomic nervous system isn't working quite right. So with the spinal cord injury, the sympathetic nervous system, that fight or flight response again, actually becomes hypoactive for the majority of the time, which in turn causes a lower resting blood pressure. So for example, it's very normal for a person after a spinal cord injury to have a blood pressure of, say, 90 on 60. So if they're having an episode of AD and you're checking blood pressure, it might read 120 on 95. And keep in mind that this might be considered normal for someone who doesn't have a spinal cord injury. But in a case of AD, it might actually signify a medical emergency. And both Kasey and Kendra will talk about this a bit further, but this is why it's really important that patients have education around AD and that they're able to advocate for themselves if they're getting AD, because not every medical professional knows a lot about this condition. Next slide, please. So this chart has many of the common causes of AD. Kendra will dive deeper into this when explaining management, but I do want to highlight that bladder is by far the most common cause of AD. So in fact, bladder irritation or distension is responsible for 75 to 85% of AD cases. This may be caused by a blocked or a kinked catheter, or even a failure of a timed intermittent catheterization program. And then bowel distension is usually the second most common cause, and this would often be from something like fecal impaction. Next slide, please. So as far as the signs and symptoms, like what are you going to find on your assessment? Well, you'll find obviously high blood pressure, but as we described, it might just be high for this individual, not for general population. Low heart rate, severe headaches, changes in vision or seeing spots or even loss of vision, anxiety or feeling of apprehension. You might get a lot of flushing or splotchiness of the skin above the level of injury, so in the face, the neck, and the shoulders. People often describe sort of this nasal congestion, and that's because all those blood vessels are sort of dilating above the level of injury. And then below the level of injury, so in the abdomen and the legs, you might see a lot of goosebumps or even chills going on. Next slide, please.
Okay, it's Kendra. I'm going to take over from here and start talking about the management of autonomic dysreflexia. So the very first step of managing it is going to be removing the cause of the noxious stimulus. And I'll go into that in a little more detail. And then if that conservative management isn't effective, then we're going to move over to medical management with antihypertensives that may be required to prevent some serious complications from forming. Can I have the next slide, please? So there was a provincial-wide autonomic dysreflexia protocol developed. This was because patients who were actually living with spinal cord injuries reported that autonomic dysreflexia was managed inconsistently throughout the province and was lacking in many healthcare settings in Alberta. And this was putting them at serious risk for developing complications. So we created a standardized direction for staff so that if you come to Calgary or Edmonton or Lethbridge or any of the smaller centers, your care for the patient with a spinal cord injury experiencing autonomic dysreflexia will be the same no matter where they go. This is also created as a resource for staff who maybe don't see very many patients with spinal cord injuries, or for staff who are really unfamiliar with autonomic dysreflexia. So there is one source of truth for those healthcare providers. Can I get the next slide, please? So on Insight, if you just put in your search for autonomic dysreflexia or spinal cord injury, it will take you right to the protocol. Otherwise, you can even search autonomic dysreflexia AHS in Google, and it will also take you right there. Can I get the next slide? This is what it looks like when you pull it up. And as you can see, this has been in effect since 2021, and it's a really great resource for anybody who may have a patient with a spinal cord injury, whether you work in acute care, rehab, or even in the outpatient settings. Can I get the next slide, please? As you can see there in Appendix A, there is the autonomic dysreflexia recognition and management algorithm, which I'm going to go into in a little bit further detail now. So for the next slide. So the management of autonomic dysreflexia. So these strategies can be applied in any setting, whether you're working in the hospital, in an emergency department, urgent care, or in the community. So if you think your patient, or if your patient self-identifies as having AD, the best possible position for them is to be sitting up in the bed or the chair. You're going to want to be planning to monitor their blood pressure every 2 to 5 minutes. And then you're going to want to start working on loosening any clothing, zippers, checking if they have an abdominal binder or compression stockings on. Even something as simple as if they have an indwelling catheter, checking the leg bag straps to make sure that they're not too tight. If you don't have standing orders, you're going to need to be notifying the most responsible healthcare provider if their systolic blood pressure is greater than 150 and they don't have any orders already on their health record. Can I get the next slide? So once you or your patient has identified that they may be showing signs of autonomic dysreflexia, maybe they're complaining of a headache, they're sweating, they're having a spike in anxiety, your first step is to try to remove that noxious stimuli. This should involve a really good full head to toe assessment. Even though most commonly it is the bladder or the bowel that's causing autonomic dysreflexia, it may not be the case. You also will want to be having a conversation with your patient to see how are they managing their bowel and bladder. Do they have an indwelling catheter? Are they doing scheduled in and out caths? How often are they doing them? When was it last done? Is there a chance with that indwelling catheter, could it be kinked or blocked? What does their normal bowel routine look like, and how effective has that been? When was the last time they moved their bowels? And then, like I said before, if they're dressed in street clothing, right, you want to be checking how those clothes are fitting. Is something too tight? And then assessing their skin integrity as part of your assessment, and looking for kind of anything that could be causing any sort of pain. Like even something as simple as, do they have any ingrown toenails? Have they been sitting on something that it is, or laying on something that is too hard? Could they be developing a pressure injury? Can I get the next slide? And this can be, when taking a full history with your patient, is critically important. There are other causes of autonomic dysreflexia. Maybe they're having menstrual cramps. Perhaps they are pregnant and starting to go into early labor. Could there be something like a fracture that they were unaware of happening? Is there any complications from an indwelling vascular device, or did they recently have a procedure without adequate local or general anesthetic. Can I get the next slide as well? So if your patient's blood pressure is high for them, but less than 150, you want to ensure that before checking for stool and disimpacting. You may want to consider using some topical gel to prevent further discomfort and making the situation worse. We want to help them bring down their blood pressure, and we want to do that without causing them any additional discomfort and actually making their blood pressure go up. As much as possible using non-pharmacological means. So you can consider using a 2% lidocaine gel before performing a catheterization or a disimpaction. That being said, if that's not available, you're going to want to go ahead and do that catheterization or disimpaction anyways. If their blood pressure is greater than 150 systolic, we do need to consider using some medication to bring that down before we complete any invasive procedures. Can I get the next slide? Perfect. So your pharmacological management, if you're unable to bring their blood pressure down with non-pharmacological means, is we're going to want to use an antihypertensive medication that has a quick onset and a short duration. So our plan is to initially treat with just 12.5 milligrams of captopril, then repeat that after 10 minutes if their blood pressure remains greater than 150 systolic. If after 30 minutes from that first initial captopril dose, their blood pressure is still high, the plan would be to give nifedipine, just 5 to 10 milligrams, and you're going to have them bite and swallow that tablet. Oh, one more slide. There we go. So captopril, for those of you who aren't familiar with the different medications, is an ACE inhibitor. It has a very quick onset and a half-life of only 2 hours, which is why we like to use it for our first-line medications. You do need to be cautious if you are giving this to a patient who does have impaired renal function. And then our second line of medication is nifedipine. It is a calcium channel blocker. It does stay in your system for up to 7 hours, which is why we like to use it as our second choice medication. And for this one, it's okay if the patient has a bit of impaired renal function, but we want to be watching for impaired liver function in these patients. So if during your assessment of your patient, there is a change in their neurological status, you want to go ahead and contact your most responsible healthcare provider. This would be if you notice a reduced level of consciousness, any new weakness or numbness, or any signs of stroke, including facial drooping, slurring speech, and vision changes. If your patient's systolic is less than 170 after you've done your treatment and there's symptomatic for hypotension, you want to place your patient in Trendelenburg position, contact your most responsible healthcare provider, and then consider IV fluid resuscitation. We consider AD resolved if their systolic blood pressure returns to their baseline and their symptoms have resolved. We then have a plan for how often you need to check their vital signs again, which is Q 15 minutes for an hour and then Q 30 for 2. And if our strategies aren't working, we are now going to consider this an emergency, and your emergency response team should be called, and you might consider a consult to critical care. And then your documentation should include what your assessments were, what your interventions were, how did they respond, and your reassessment, and then the ever important education that you provided for your patient. So if you've noticed a knowledge gap, you can then start to provide some education for your patient, which includes for them recognizing the signs and symptoms of autonomic dysreflexia, noting that it can present differently in different people, understanding and tracking personal triggers, what pharmacological and non-pharmacological management works for them, when they need to call for help, and how to advocate for themselves. And then I'm going to turn this over to Kasey.
Thank you, Kendra. Being someone who's lived with a spinal cord injury for 23 years now, and I have a C6, C7 Asia C injury. I'm well versed in the ways in which AD have affected my life, and those friends of mine are peers in the SCI community as well. It was a combination of those AD experiences, AD lived experiences, in collaboration with the NRV, so that's the Neuro Rehab and Vision, a strategic clinical network within Alberta, that the AD pocket card you guys are seeing on the screen here was created. This card aims to provide immediate info about autonomic dysreflexia and directs AHS staff directly to the protocol for recognition and treatment. This card can be found on the My Health Alberta website, in addition to Spinal Cord Injury Alberta. And we are actually just starting to hand this out in our SCI education here at Foothills Hospital. And next slide, please. So if you suffer from AD, if you suffer from autonomic dysreflexia, or care for someone who experiences it, I highly encourage an awareness of what that new baseline blood pressure looks like. To be quite honest, it took a few years, but after much convincing, one of the nurses up on Unit 58, Tanya McFall, she convinced me to really invest in a blood pressure monitor, and it was only about $50. But I'm very thankful that I have it now, because I can check my blood pressure when I'm feeling a little bit off or even super tired, and I'm aware of how low my blood pressure is. It's also really good to know, like, in case you happen to go somewhere and they go to check your blood pressure, I kind of give them a heads up. Hey, I have really low blood pressure, like 90/50 is considered normal, where normally they would be like, this is very low. No, this is my regular. So learning to listen to your body with a spinal cord injury can be quite tricky, but something as simple as getting a blood pressure monitor and learning your baseline blood pressure can be a very powerful tool for wellness. Next slide, please. All right, so I just wanted to share a little bit, some symptoms, some types of symptoms that I experience when I have AD. One weird one is, my hearing. You can be sitting right in front of me talking to me, but it will sound like your voice is coming out of the bathroom around the corner. It is very hard to explain, but that is one of the symptoms that I experience when I have AD. The other are goosebumps, immediately goosebumps. My lips actually go quite white or purple, and pounding headaches in really bad situations. So I've had, some funny situations where I've had AD, and then a few more serious ones. But a blocked catheter made me just go through the roof with AD, and tried to experiment with some Metamucil pills, get in a little bit more fiber, and it didn't really work well for me. So I ended up in the ER, and I was very glad to know that my baseline blood pressure was where it was, and that even 130 or 90 was extremely high. So just being able to convey that to them, that something is seriously wrong here. We were able to sort it out. I know not to play around with those anymore. But overall, what I'm trying to impress upon you guys is that, most people manage their AD quite well in the community. But it's those times where it gets a little out of control, and it can be quite scary that they will come into or call EMS or come into AHS emergency department. And so I'm really hopeful that some of this information we provided and some of the stuff that I shared will be helpful when you're presented with someone who's experiencing one of those more serious episodes of AD. Thank you.
Sorry, I'm coming back. Okay, thank you so much, you guys. We've got a couple extra minutes, which is great. I've got a few questions here. One from Alicia that says, if you are unable to immediately take away that noxious stimuli, for example, a pressure injury, is the goal to manage the blood pressure with medications until the pressure injury healed?
Yeah, that's a great question. So I've certainly followed folks with, either pressure injuries that are constantly causing AD or other things that just aren't readily reversible, right? So like say you have a fractured limb or a really big sore, like even an ingrown toenail, like that doesn't go away just, within a couple minutes. So typically in those cases, we recommend treating the pain. So even though you're not actually like your brain isn't responding and noticing the pain, your body is. So that can be really helpful, just pain medications. And you might need like, a pretty strong one, but usually we recommend starting off with sort of the lowest dose. So like Tylenol or Advil, and then go up from there, depending on what the injury is. And then some patients are chronically getting AD and we don't actually find the cause. And so for those patients, we might actually use a medication like prazosin or clonidine to try to treat that chronic AD if we're unable to find the cause.
Thank you. Sarah's asking, at what point would AD be considered a code nursing response while admitted in hospital and patient is off the medical unit, like in a physio gym?
I can probably take this one. So I would say that if your patient is off the unit and in, say, the physio gym or elsewhere, and you have a concern that they mention that they are feeling symptoms of AD, the first thing that I would do would actually be to contact the nursing unit and have a conversation with the nurse and then get the patient back to the unit so that an assessment can be done there. That being said, if it's something rapid and you're noticing any neurological symptoms, having worked in ICU for a number of years and being on the emergency response team, we would rather that you just called us and you didn't need us rather than waiting. So it's absolutely okay to call for help and have them come and realize that you don't need them rather than waiting too long.
Thank you. The next question is, I'm curious about how common it is for athletes with SCI in our community to provoke AD for boosting. Do any of the SCI community members here know if this is still done?
I guess I can share a little bit about that. Not that I'm familiar with it, but when I was involved in like high performance hand cycling, I know that some people were doing it. It's sort of similar to like blood boosting. It would just give them a little bit more energy, although I find it actually quite scary that they would put their lives at risk just to really push their blood pressure through the roof to get a little bit more of a bolt. I don't know if people still do it, but it's well known in the community that some people do it.
The next one is, I have a client living in the community with a C6 SCI. He has autonomic dysreflexia, but recently has been finding that his symptoms are worse and are triggered more easily. He is quite aware of his triggers and how to mitigate the symptoms, but is it common for it to worsen over time?
Yeah, I can take this one. I'm not sure if it's necessarily common to worsen over time, but I've certainly seen it worsen over time in certain cases. And in these cases, it can be quite challenging, but usually just kind of go back to the basics. So the most common thing is bladder, right? So that will be the thing that, with urology's input, we direct our focus to first. So some patients need medication for their bladder. Some patients need Botox or to change up their bladder management strategy. And then the next step would be looking at the bowel routine and just making sure that there's nothing being missed there. And then in those cases, it can be really challenging and you end up, ordering imaging or lab work or just really trying to investigate to try to find those causes. And like I said, there's some cases where we don't find the underlying cause and we end up treating with additional medications kind of prophylactically.
Thanks, Rebecca. How soon post SCI is the new normal BP established?
Oh gosh, that's a good question. Most people are in spinal shock for a couple weeks, even up to a month or more. So, in that first acute period, I would say like nothing's quite stabilized yet. A lot of patients acutely after injury have a lot of problems with orthostatic hypotension. So their blood pressure is dropping. So it's kind of the opposite problem. And that does tend to stable out over the first sort of 6 months. But yeah, sorry, I don't have like a specific point in time where the new normal would be established. I'm not sure like if Chester or Hardeep would weigh in there.
Yeah, I would say generally that bradycardia and the autonomic instability you spoke about usually resolves after 6 weeks. And then following 6 weeks, if they don't have any other comorbidities, then generally they're at their baseline. Because when they come into rehab in our inpatient units, that's when we kind of, as long as they're not having any AD or significant orthostasis, we can define their baseline there. So generally after 6 to 8 weeks, I would say.
I think, Rebecca, the only thing that I'll add there is, do we really want to accept that as the new normal? Because basically, even if the blood pressure is generally lower after a spinal cord injury, is that okay? Because I think that there's more and more evidence to show that when the blood pressure is lower, right, it may actually have subtle cognitive effects on people. And so while we see and recognize that the blood pressure is generally lower, but is that the new normal or is it just a new finding that we have? I think that we need to learn more about that.
Yeah, I would fully agree with that. I think, the last couple of years going to conferences like this is always a topic that's explored, and just like the long-term effects of having low blood pressure. And in Calgary, they're doing the trials right now with epidural stim to kind of boost blood pressure. And, some of those outcome measures, like those are the things they're looking at in animal studies and hoping to apply it to humans too. So yeah, I would agree. I think we're still learning about the ideal blood pressure targets.
I have a question from Sarah. If you remove the triggers, such as empty a urinal bag, will this always stop the autonomic response, or will it sometimes continue on and require intervention?
Yeah, so I would say like if that's the trigger, then yeah, typically it resolves as soon as the urinal bag is emptied, or say the catheter was kinked or blocked. If the catheter's changed, yeah, typically that resolves the AD.
Okay, I have a question for Kasey as well. Are there any tips of what to pack for when you go out to work or school, like a list of supplies to help manage AD when in the community?
Good question. So I guess I've learned through bad experiences with AD that I now always just have my backpack and have some extra catheters, leg bags, and a couple extras, because I can't rely on that one leg bag working 100%, or the one catheter not being defective, and a syringe to inflate those. So anywhere, if I happen to have a blocked catheter or bag, I'm able to switch that stuff out. In addition to like a pair of underwear and pants in my bag as well. I highly encourage other people to just have that little bit of a safety net, because it's usually stuff that is not easy to find, that we'll need to help alleviate AD.
Thank you. And then to Rebecca, are there different levels of AD or different severities?
Yeah, good question. There's not really like a grading scale. I would say anytime someone has AD, it should be treated, as it is a medical emergency. There are definitely, different scenarios where it might be really easy to reverse someone's AD. So say it was something as simple as like accidentally sitting on a hard object, like, you remove that, the AD will be reversed right away, versus the other examples we gave, like say someone has a fractured bone or appendicitis, like that AD is going to be much more difficult to treat.
And I think probably one more just before we go for a short break. At what point in an AD episode should someone call emergency 911 in the community?
Yeah, so I would say it's, when a patient or a person with spinal cord injury has gone through their usual checklist and they're just not able to get that blood pressure under control, especially when that systolic pressure is at 200. And they've done all their usual things, check the bladder, check the bowel, check the skin, the clothing, sat up. If they have their own prescription for medication, they've tried that as well, and it's still not coming down, that's when it's appropriate to call 911.
Great. Thank you so much, you guys. That was very informative.